Warm good evening and good evening to all of you who have gathered us here. On behalf of the Indian Psychiatric Society Tamil Nadu chapter, our greetings to our president, Dr. Sadanand sir, our EASY members, and all other colleagues who have joined us here. This is our fourth consecutive child psychiatry webinar. Child psychiatry webinar series is organized every fourth Saturday. So today we have an interesting topic. Children of parents with mental illness, and this topic will be delivered by a very eminent speaker. We have Dr. AKHILESH Sharma sir here. A brief introduction about the speaker of the day. Dr. AKHILESH Sharma is currently working as additional professor in the Department of Psychiatry at PGIMER Chandigarh. His areas of interest are child and adolescent psychiatry and consultation and liaison psychiatry. And he has published more than 105 research publications in journals. Over to you, sir. Thank you for joining us here.
Thank you, Dr. Shinika. And I am thankful to all of you that you have given me a chance to present this webinar. So why I took this topic for the evening is that generally as mental health professionals, whether we are looking, most of us practice in general psychiatric settings and see all type of patients. And generally we talk to the patient regarding their symptoms in our busy clinics, how are they? And even when mostly these are admitted, then only we talk about them in details. We don't ask about the family members, effect of family, generally in our busy OPD setting. We all know that nowadays in health sector, we talk about preventions, especially non-communicable diseases, diabetes mellitus, hypertension, coronary artery disease, and related diseases. And similar trend has now also started in mental illnesses also. These are also a very important group of non-communicable diseases, comorbid with other non-communicable diseases. So when we talk about this prevention and promotion, we need high risk groups. Children of parents with mental illness is one such high risk group. It provides us opportunity for prevention, promotion of mental health, as well as it also provides us opportunity to study these, to develop new ways of by which we can prevent and promote the mental health of these children. So this is the reason I have chosen this topic. Where is the slide? You are visible to me, Dr. Shinika. Note the slides. Now they are visible. So this present my student, Dr. Mirza Sarwar Beg, who is doing his training with us in child psychiatry, has helped me in preparing this presentation. So this was a very popular movie which was based on a real life incident.
Sir, can you please try sharing your screen again, sir?
Screen is not visible.
So you're visible. We are not able to see your screen.
Okay.
The share button is at the last row.
Share. I am able to see only the presentation, not the...
So the green color bar.
So the green button, the upward arrow at the bottom, which you tried at the...
Okay, ma'am. Okay, ma'am.
Yes, sir. Yes, sir. We are able to see now.
Now you are able to see the presentation?
No, sir. We are able to see your screen. You can go to your PPT and then make it a slideshow, sir. Yes, yes, yes. Yes, sir. Yes, sir. Perfect, sir.
Okay. So,
No, it's,
is it visible now?
Yes, sir. Yes,
No,
sir.
it
It's
is not
perfect.
in the center screen. Okay, fine.
Yes, sir. Yes, sir. It's perfect, sir.
Okay.
So in popular media also, these things have been talked about, especially in the developed countries. And one such very popular book was written by a children of parents with mental illness, with severe mental illness, which has been very popular in Australian and New Zealand islands. So these children of parents with mental illness, they are at risk of genetic risk, the biological factors, because of the very important point that they are children of parents with mental illness. They are having psychological risk factors. They are having social stressors arising out of the mental illness of the parents. And it increases the chance of their developing mental illness in the future. And there have been put forth various theories regarding this. One such theory is called consistency theory, and it assumes that 4 basic needs of humans, they aspire to satisfy, and these protect them from harm: attachment needs, orientation and control needs, pleasure and self-enhancement needs. And being a children of parent with mental illness, I will call it COPNI. So they are not able to achieve these basic needs. Now you can see this is a chart which depicts the adversities which a child generally faces, and this is a chart taken from WHO. And here you can see in the household dysfunction there is mention of mental illness. Now mental illness and severe mental illness per se is regarded as the most severe form of childhood adversity after the sexual abuse. Now, having one adversity invites other sorts of adversities also. It has been proven by the research that if you are children of a parent with mental illness, you will be, your other family members will be treated violently by the ill family member, or the person with mental illness will be treated aggressively or violently by other family members. At times there would be parental divorce, parents might be using substance, there would be physical abuse, there would be physical neglect, there would be emotional neglect, and there might be sexual abuse also. So this invites all other sorts of adverse childhood experiences, and these has been studied in detail. These adverse childhood experiences have been studied in detail. Initially, the method of study was cross-sectional, that those children of parents with mental illness who have grown to adulthood, they were interviewed through questionnaires, through semi-structured interviews, and the study on adverse childhood experiences was done. But there were recall biases and other sorts of biases. So in the last 2-3 decades, people have started studying these longitudinally in children and adolescent age only. So now the data is more reliable. So what the data says? Data says that COPMI children with severe mental illnesses receive severe form of these physical abuses, sexual abuses. And if the duration of abuse is long, duration of untreated mental illness in the parent is long, multiple type of abuses are present, then the future risk of school dropout, of having physical illness, of having poor social functioning, and having a mental illness increases. You can see from this slide that there are a lot of psychological issues which these children face. The feeling of guilt that they are having a parent with mental illness, and they have to do multiple tasks which they are not supposed to do in this tender age. And one important thing is that these children become hyper alert of their own behavior, and they become fearful as they reach the late adolescence or the level of cognitive maturity. They start being alert of themselves. If they develop some sort of symptoms that they are not, they fear that they are going to be like their ill parent. So this may lead to anxiety in them. And these parents are themselves who's when they perceive themselves to be sick, they are not seeking treatment because of fear of stigma. and losing the custody of the children if there is a ongoing marital conflict or divorce. We are not having an exact data, but these are estimates from the various literature available that 15 to 23% of children live with a parent with mental disorder worldwide. And those who attend a clinic, those children, adolescents who come for mental health services, among them, 1/3 are having a parent with mental illness. And being COPME increases a risk to develop mental illness 2.5 times. From the last World Mental Health Survey, it was seen that if one parent has a mental illness, the chances of developing a mental illness increase. And if two parents are having a mental illness, then it increases to 2 times the amount. With one parent, about 2.2, with two, it is about 4.5. Now, if the parent is having a severe mental illness, then their parenting capacity gets hampered more in comparison to the parents who are having depressive disorder or neurotic illnesses. And they need more support, and their children are at more risk. So, when as a healthcare professional, we are dealing with these parents, we should keep in mind their parenting identity, because it has been seen in research that if we recognize them as a parent also, and during their phases of recovery, because recovery is a very broad concept, and they might be at different stages of recovery, and they might be having different resources, but still we need to recognize that how they feel themselves as a parent, how confident they feel themselves as a parent, and we should try to inquire about this, because it has been seen in research that this is not generally inquired. So they say that there are 4 basic ways of transmission of mental illness from the mentally ill parents to the child. Sometimes there is a specific mental illness in the parent, but it increases the risk of all sorts of psychiatric disorders like schizophrenia and bipolar disorder, increases the risk of all sorts of psychiatric disorder, major, minor, common, severe. There might be a concordance that parent is having a bipolar disorder, child will develop bipolar disorder. There is a chance that different mental illnesses in the parent might be having schizophrenia, other parent group might be having bipolar, other parent group might be having some neurotic illnesses. They all tend to increase this risk of one particular psychiatric disorder in children, like most commonly depression and anxiety. And at times, are specifically related to the parent's diagnosis, that anxiety in parent leads to anxiety in children. So if we see that these are the mechanisms, and these mechanisms are not only due to the biological reasons, they are due to the psychological reasons, social reasons, and environmental reasons which occur because of the parental mental illnesses. This slide also tells about some risk of mental illnesses. Now, there are other outcomes that not only having a mental illness, but also having school dropouts, poor social functioning, poor achievement in the adulthood, and likelihood of having physical illnesses increases in children of parents with mental illness. Because originally when the ACE studies were done, they were done in children who were having these physical illnesses like obesity and other physical illnesses. And so these children are at risk of other poor outcomes. Now, one particular poor outcome which has been seen in COPME is parentification. That these children often care for and support their parents physically and emotionally. This results in role reversal. There are boundary distortions, that who is the parent and who is the child. And there is inverted hierarchy. So parentification is an indicator of poor outcome. Other adverse outcomes I have discussed, that there will be stigma, teenage pregnancy, neglect, and all other sorts of childhood maltreatment can happen. Now, if we see that in non-communicable diseases which are of physical nature, there is less genetic contribution. For you take example of diabetes, genetic contribution is around 1/3 to 1/2. But if you see, more number of children tend to develop this, and there might be a complex interplay of genetic and environment factor. But if you take example of these severe mental illnesses where population risk, the heritability thing from the genetic studies is very high, 80%, 90%. But you see that in spite of this genetic high risk and it itself being a very severe form of childhood adversity, inviting all other adversities, still the conversion rate of having a severe mental illness is very less in comparison to less genetically determined counterpart physical illnesses. So there are other factors which are protective factors, which are resilience related factors, which also interplay with these adverse factors to determine the outcome. So there are protective factors also. What are these factors? These factors are described as resilience broadly, and resilience can only happen in case of an adversity. And PGIMER provides us a perfect example of adversity. So there are various factors which have been studied. There are ongoing longitudinal studies. One good example is Danic high risk and resilience study. And in that study, they have seen that those children who are at genetic high risk, they have divided them in low risk, moderate risk, and high risk. And they have compared them with healthy controls. But if they are having good resilience and they are having severe trauma, then their outcome is not as worse as it in case of a low resilience with severe trauma. So now it has been shown longitudinally also that resilience and adversity interplay, and then it can cause some sort of differential outcome. One such thing has been seen in Indian study also, that it shows that 40% of the PGIMER has medium level of resilience, 33% had low, and 26.7% had high level of resilience. So resilience factors are also important, and these are the factors which are modifiable, which are not like the genetic factors. One such factor is social support. We did a study in our department where we studied the risk of progression to bipolar disorder in ultra high risk children where one parent was having bipolar disorder. And based upon a risk calculator given by the Petersburg group, we calculated their 5-year risk, 1-year risk. And we were surprised that our risks were very less in comparison risks in the American papers. We examined the various factors, and then we see that in Indian society, there was social support. Family were not completely broken. Some grandparent, some mosi, mama, or other relatives were available to provide the support to the child. Schools were also more supportive. And so these factors are very important. One person from the Scandinavian country, this Beardsley, he works a lot with the children with PGIMER, and he has developed various interventions also. He says that resilient young people whose parents had mental illnesses were able to distinguish between themselves and their parents' illness. And this is a very high, this is a factor which is associated with very higher level of coping. I will discuss those two types of copings, and this factor which he has studies is associated with high level of resilience, or what we may call as coping. These children who are resilient, they are very much capable of showing empathy, and they are very much expressive of their own emotional states. So these two types of adaptive copings have been seen: primary control coping and secondary control coping. And this primary control coping shows those factors which have been mentioned by Beardsley, that they use problem solving. They can distinguish between their own things and their parental things, and they can emotionally express these things. They have emotional modulations. And these children are found to have good positive mood, less affective problems, and less aggression. Other group of children who have medium to low resilience, they use mostly acceptance, positive thinking, distractions, etc. And here the positive outcomes are less, but the harm reduction is there, that they tend to develop less anxiety and depressive symptoms. They have less affective problems and these externalizing problems.
हेलो
Hello.
ओ भी बात होते हैं 2 मिनट
हाँ जी. So the resilience factors which have been studied in COPMI children, they have been divided into broadly 5 factors. One is information, that a better understanding of parents' mental illness provides resilience. It is a protective factor. If there is a social support by a co-parent, by other family member, by a sibling, then it is a protective factor. Family functioning and connectedness within the family as a whole or with specific family members or friends, if there is a holding hand, it is a protective factor. Coping things, if the child is able to cope, I have discussed the 2 types of coping. How they cope, it determines that how much they will be resilient of the bad outcomes. Then parenting. Parenting is the most important factor, because now the parenting of the mentally ill parents have been studied in detail, and this can be improved by interventions, and it is a very important protective factor. So these 5 protective factors which have been found in literature, they have paved way for the interventions which have been developed and tried. There are very few interventions, but the foundation are these 5 factors for those interventions. So in a other way, these factors have been classified in individual, intrafamilial or contextual levels also. So one such thing which has been found to improve the outcome in these children is that we should treat mentally ill parents as much as possible. And it has been shown in the longitudinal studies. Some studies have some initial study had some heterogeneous outcome, but the newer studies have shown that the depressive outcomes, anxiety related outcomes, they are less if the parents are treated on time.
I don't want you to overthink.
There is a
So
STAR
this is your
study,
adult
the popular
ADHD. You
study,
need to read
systematic
within the
treatment
past
alternative to
month,
relieve
whatever they are
depression.
watching.
There was
That's
an
the
Oxford paper which
Yeah.
has shown that
mark it with a pen.
children of mothers whose
Just
depression had
they
remitted
said, no,
early
cross
had
it out.
fewer externalizing
Read
problems.
it, you will get to know.
The interventions which have been developed on the basis of these
Sir, unable to hear your voice.
Sir? Sir? Hello, sir. Sir, we are not able to.
ओके
Yes, sir. Yes, sir.
साइड से म्यूट था, मैं दोबारा बताऊं क्या?
Yes, sir. Yes. No, sir. We are able to hear you, sir.
नहीं, ये वाला स्लाइड बता दिया था मैंने ट्रीटमेंट वाला.
Sir, no, sir, you can please start from here, sir.
Here,
The next slide.
this,
Not the next slide.
this.
Yes,
So
treatment.
the important intervention which we can do is to treat these ill parents, because their early treatment, their less duration of illness, the less exposure of their severity of illness is one of the factors which has been found to improve the outcome in children. So if they are severely ill for more times, the outcomes will be bad. And this has been shown in a lot of studies. Now, based on these factors, there are various interventions which have been developed. One such intervention has been developed by this gentleman who has worked extensively in this area from Scandinavian countries, and it is a family talk intervention. It is a manualized 7-session therapy which can be developed, which can be delivered by mental health professionals even with minimal training, and it is easily available online, and you can go and see it. And there are sessions. In the first session, they talk with the parent regarding their illness, their problems. In second session, they talk with the parent regarding what they think the effect of their illness is on the children. In third session, and also they talk that now we should bring the children to the third session. They talk to the combinedly, they talk to the children that what are the problems, what they think of their parents' problem, how they are coping, and then the joint sessions are held. The main goal is to enhance children's knowledge about the parental disorder. That it is similar to psychoeducation, but it is done in a developmentally sensitive way, in a individualized manner initially, and there are group interventions also. There are individual interventions also of this family talk intervention. There are online, there are person-to-person intervention. These are the variations which are available. So this has been studied, and there are RCTs which have been done on this, and the RCTs have shown that these improve family functioning, the parental guilt, the parental sense of competence of their parenting, the children's anxiety, depression, etc. Other intervention, which is child's talk, and it has been developed in Netherlands, which is also a manualized intervention. It has only 3 sessions, and here mental health workers talk with the family about situation of children, their needs when a parent struggles with mental health issue. So in family talk intervention, there is a family based approach, and in child's talk, there is a child-centric approach. So this is a snapshot from the site that what we do in the first meeting. In the first meeting, both parents are called. They are explained the purpose of the meeting, discuss the mental illnesses of the parent. They inform the parent about impact of their illness on the child. They inform about the protective factors after their workup also, which are present. Then in the next meeting, both parents are called. They discuss how parents can discuss mental illness at home. They view some examples, role plays are done, that how it can be done. Then they prepare parents to take charge of meeting with the child. Then third meeting is children and parents together. They hear the discussion of children's experiences is done. Their questions are listened, and information about mental illness is given. In the fourth meeting, there is evaluation of meetings, questions, next steps, that what are the points of interest for the family, and referral to support options, schools. And there are peer groups. There are other families who are suffering these sort of issues, and they are not alone, and there are social security agencies involved. There are other stakeholders than the mental health services. So they are also brought into the picture. So now it has been seen that there are various systematic reviews which have seen all these interventions which are done for COPMI children, and psychoeducation is one of the most important component, and it has been found that it increases resilience, and it is the psychoeducation, that it provides understanding of the parents' illness, and it provides them some sort of support or tools that how they can manage their parentification. It enhances their social skills, their coping skills, and social support is generated with whatever available resources are available. and it reduces their feeling of guilt, shame. It promotes their resilience, and their knowledge is strengthened about their parents' difficulty. And some of the interventions which have also been studied is training in their emotional regulation strategies, because in the coping strategies, we have seen that those who can express themselves and regulate their emotions easily, they are not having bad outcomes. Peer support has been instrumental because it allows children to share their fears and experiences, that they are not alone, that they can learn from the others. There are multi-family groups that foster the notion that other families experience the same issues, and shared experience can reduce the feeling of shame and guilt. On the website, there are various simple things which are available, which are very cheap, and these have been used by the experts as well as by the families themselves, that how they can teach their child about their parents' illness, educate them, they can provide them some information, and they can provide them some ways to cope with it. There are challenges for prevention and intervention, that there is low utilization of services to support COPME. Now in India also, after this United Nations Conventions for Child's Right, there have been development of services, though slowly, but they are available at district level. But generally, the healthcare professionals are not sensitive. If they are sitting in the adult healthcare settings, they don't ask about the children. And if they are sitting in the child care settings, still in the busy OPDs, we tend to forget to ask about the family situations and parental mental health. It is said that if the mother is having a depression, or the important caregiver is having a depression, then it is akin that it is said that the child is living in a dark room with an elephant, the elephant being the mother. So we should enhance the awareness of the mental health professionals, and we should also give them knowledge. There should be training sessions, that this much can be done, which is being done in the developing country, other developing countries like China. One particular therapy, I am forgetting its name, it is akin to child's talk. And it is being done in China on a public health basis, even in the primary health care, secondary health care, and tertiary health care, and in the community. There are randomized control trials which are looking at these things in the COPME children. Important is Danish high risk and resilience study, which I have talked. There is one study which was started in 2019, the COMPARE study, which examines the effect of children of parental psychotherapy compared with parenting psychotherapy along with a parenting program. In one group, there is only parental psychotherapy. In other group, there is also a parenting program. I could not find its results. In one third study, it has focused on identification of COPME within adult mental health system and facilitation of collaborative care, and it has improved the outcomes. So there have been some encouraging development in this field in the India also, like the development in the perinatal psychiatry, where the mothers and their infants are kept together from old mental health asylums and the mental health care inpatients units. We can see that we would generally discourage the visit of child. Families would discourage, even the mental health care professionals and other staffs would discourage. But now the things are changing. They have changed in the West, they are changing in India, and it has been found that they are not harmful for the children. There is rigid hierarchical structures of Indian families and emphasis on kinship obligations, which are important factors which we should address in implementing these things in Indian setting, because in India, formal foster care is uncommon. Rather, if a parent is having mental illness, child are being taken care of by aunts, paternal, maternal aunts, or other extended family members. So things are in developing phase. So there are some practical steps that we should identify these children. We should have in our mind that we should ask for the children in the adult care setting also, from the parents who are seeking help for their mental health issues. There should be open communication within and outside the family about parents' mental illness. And it has been shown that it doesn't causes anxiety or doesn't causes some sort of weakness or in the child. Rather, it helps. This is the thing which has been found to be helpful in the research. And we should screen the child for the mental health issues, because COPMI children have mental health issues. Earlier we detect them, then it has been shown in the research that the trajectory can be altered. So now they say that the physical and mental illness, their comorbidity is high. And if the parents are in the primary care setting or the children are in the pediatric setting, there are chances that they or their family members are having mental illnesses. So developed countries, they are also having programs to detect and treat them. Thank you all for a patient listening. Shinika ji, I am audible.
Sorry, sir.
I am audible.
Yes, sir. Yes, sir. Yes, sir. Yes, sir. We could hear you, sir.
I think I have finished in time.
Yes, sir. Yes, sir.
This is a chart which shows the interplay of these various factors, parenting factors. There are risk and protective factors for maternal depression and in parent from their own experiences. Then there is a mentally ill parent. There we should look at the chronicity, the severity of their impairment, their coping skills and parenting competence. Then we should look at the broader family context beyond the parent, that there is a marital discord or not, divorce, violence, life events, low income, poverty. How is the other parent? Is it present or absent? Is he providing positive care? How is his parenting, his or her parenting competence? Their knowledge about partner's mental illness. And then there are vulnerability and resilience factors which interplay at various levels, parent-child interaction level and the societal and other stakeholders level, and they determine the outcome of these COPMI children. This sort of summarizes the things which I have discussed. Thank you.
Thank you very much, sir, for
I
such a
think
good
other people can
explanation.
share their experiences. My aim was only to sensitize our fellow colleague that we should keep in mind in our general practice setting, inpatient setting, especially in OPD settings, to ask about the children.
Thank you very much, sir. So we have one question on the chat box.
Can you read the question?
Yes, sir. Yes, sir. It's difficult for treating a parent. If we want to treat or even assess the child, won't they leave treatment?
Dr. Bedi, it is not always the case. These are the things which have been found in research, that these are the barriers in the mind of mental health care professionals. If you have a good rapport with the parent and they have developed faith in you, if you are genuine, then there are points when they themselves give the lead regarding these issues. We are not sensitive enough to catch these. So this is what I want to convey with my presentation and with my little experience of 10, 13 years with children, that this thing, this is a barrier in mental health professionals.
I request the audience to unmute yourself and ask questions to sir.
And others can also contribute their experience, because this is such a topic that your experiences can be valuable. Dr. Beg, if you have joined, you can say something. I can share some other slides also to show Danish studies till others can think of questions.
Sure, sir. Sure, sir. Will please share, sir.
Is it visible?
Yes, sir. Yes, sir. We are able to see your screen, sir.
This was the other presentation which I have made. So this is one of the paper from that is high risk study. They have done other papers also that these are the tertiles which have shown that functioning जो है वो y axis पे है. On the x axis there are two trauma severity and these are the resilience tertiles. High resilience tertile with severe trauma, still the functioning is better. Moderate resilience tertile, if the trauma is less, then functioning is more. The trauma being more, they interact in a way that the functioning decreases gradually. These are for non-psychiatric participants. It happens with both, that the decline with the severity of trauma happens in both healthy children as well as with children of parents with schizophrenia. But it is more in case of children with schizophrenia. So genetic risk is only one thing. Other factors like childhood adversity and resilience are more important in spite of more genetic risk.
Good evening, sir.
Good evening.
Sir, I'm Dr. Raman, sir. So thank you so much for throwing light on this topic, which is generally not addressed in the clinical setting. So just wanted to clarify, is there anything to do with like the birth order of the child? So like other studies which has looked at birth order of the child, like the firstborn who copes well with parents of mental illness? Or is there any trajectory of like, if you have a parent of a mental illness, like have there studies looked at like children, what are the illnesses or like psychological issues that they develop, and when they grow as adolescents, what happens, and when they grow as adults? Are there studies that has looked at like that, sir?
Okay. So there are studies which have shown that if a parent is having a mental illness and if the child is exposed to the severity of mental illness at a developmentally sensitive and critical period, and there were less of the protective factors during that time, and the abuses were more, that is the whole nut sum of adversity was more, then there are chances that they will have overall bad outcome in comparison to those who have not met those, in spite of the fact they are having the parent with a mental illness. Comparison of two children with the parent with the mental illness of same illness, but if the duration, severity of trauma generated by the illness severity and lack of other protective factors is more, then the outcomes are bad. And it is more in if we compare it with healthy controls, but even for the same group, if the trauma severity and duration is more, overall functioning, educational outcome, physical health outcome, mental health outcomes are worse. But I am not aware of the birth order.
Thank you, sir. Thank you so much.
Sir, there are two more questions on the chat box.
Okay.
The risk of NDDs in children of parents with mental illness.
Yeah, it increases. It increases, as I have shown that there are 4 pathways, and the basic thing which the adversity does is that it increases the risk of disrupted neurodevelopment. You can see from this slide that first there will be disrupted neurodevelopment, then the other things as the child develop, these impairments which are available, which are visible in the form of neuropsychological measurements or behaviorally, emotionally, socially, they appear, then the other sort of problems appear. Yes.
So the one more question is functional and somatic symptoms in children of mothers with anxiety disorder.
Yes, I mentioned one particular study that in anxiety or neurotic disorders, the similar symptoms occur in the children in spite of less genetic risk.
Okay, sir. Thank you, sir.
Dr. Vel Prashant is there or not?
He's not there, sir.
He is not there.
Sir, are there any specific parenting programs for these parents, sir, which can help them with parenting their children? Any specific parenting programs that we
Yes,
have or group format?
while
Interventions.
I was preparing this presentation, I met I saw some papers where these are mostly from the Scandinavian countries, Netherlands, other countries, but they have involved authors from these 24 countries, Australian continent also, and these European countries. They write a lot about it, and they have a program. They have done trial that it is there, and still the trials are going on. And one such study I mentioned where parental psychotherapy was given to Cockney parents, and other in psychotherapy, in addition, parenting program was also given. So it yielded better outcome.
Sure, sir. Sure, sir.
But I am not aware of such parenting program in India
Okay.
or China.
Sir, what is your experience in working with any group interventions organized for these parents or children, sir, for these children? Group interventions in Indian settings and your experience on that, sir?
My experience is related to very small groups. Generally, the inpatients been admitted frequently in our ward group of three, 4. There we have done. Some of my colleagues are also there. So there we have found that these things have helped. I will share 2 examples with anonymity, 2-3 examples, that there was a adolescent male admitted with acute schizophrenic psychosis, and after admission we came to know that both of his parents were having severe mental illness, divorce, and now the other caregiver, social support, they also died recently, grandma and grandpa, and there were all sort of abuses, less not only but just there was no sexual abuse, other sort of adversities were present, but he was good cognitively. He had studied, he had good marks, but he break down when the social support of grandmother and grandfather was gone. His only elder sister was also having was schizo-obsessive, and then we took this family. There was one other family where the child used to bring mother for the OPD only in 7th class, and mother was well educated. There was a divorce, she remarried again, there was a break in the family, and the paternal grandparents were paternal uncle was abusive to the child, but he was having very good resilience, and in the good times mother was taking good care of him, and his father, even after the divorce, was providing him money and the support in whatever way they could. So we have done, and one more child was there. We have done some sort of interventions based on these principles only. After reading these principles and taking help from other extended family members, contacting them, like the father of that boy, other uncle who for that family where all children were having schizophrenia, and talking to the college, their reintegration into the society, and now they are doing well. So I think that these interventions can be tried. Now there is a good amount of support available in India also, because the other agencies which we need, the school, the college, the child protection units, and other NGOs, now they are available in at district level also. if we try to reach them, and other sort of help is there. So I think these things can be done. At least these interventions, which are of 3 sessions only, child talk, it can be done. It is available on that site. It is available in Bengali, Tamil, Telugu, Hindi. They have translated it. The Australian group have translated it in all these languages for the persons who are speaking these languages, the migrants, they are residing there. It is available.
Sure, sir. Thank you very much, sir. Thank you. We request the participants to unmute and ask questions. Are there any more questions?
Dr. Beg, you want to say something? You have helped me. You have prepared all the presentation.
Nothing, sir. I'm sure you've covered most of the points, sir. I was just able to join, so I wasn't able to follow the thread of the discussion so far. So I'm
You
pretty
can
sure.
talk about something which is available in the print media, the social media, and the other things that you have mentioned.
Sir, this particular, sir, there's some background noise. I think there might be disturbance, so I'll speak in a couple of minutes. I'll just wait for the announcement to get over because I'm traveling.
Okay, 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 okay. Thank you.
Good evening, sir. Sir, does this warrant if we are encountering children of parents with mental illnesses? So because many of us have strong biological leanings, does this warrant a watchful, attitude of a psychiatrist? Because we might encounter some fleeting psychotic symptoms, or we might encounter some non-specific symptoms through developmental periods, because we are seeing the adults in our clinics. We might be seeing our adults in our clinics. So how how much of an additional caution should be exercised when we encounter symptoms that are subsyndromal in these kids? Or is it our biological skepticism acting in these situations?
See, Chaitanya, it has been shown in literature with lot of studies that adversity, genetic adversity, there is a popular paper in the Nature that having a genetic predisposition for adversity like severe mental illness, because of that very genetic predisposition, you are temperamentally wired in such a way that you approach the adverse environment more than the safe environment. It has been shown in ADHD, CD children. So if we are having a parent and who is seeking help for a mental illness, even though the child might not be having any sort of symptoms, still we must ask about the child, the others in the family. And if, as you are saying, they are having some sort of symptoms, these symptoms are future predictor of other sort of difficulties, including mental health disorders or problems of various. Not only the particular illness the parent is having, the physical health outcome, the school related outcome, the social outcomes, and even the effect on their own parenting in future. So
Thank
we
you, sir.
must watch them carefully and we should provide them interventions.
Thank you, sir.
So Dr. Shinika, I think now it is 8:15, and if there are no more questions or comments.
Sir, just the last point to just make myself, just Dr. Raman here.
Ji,
So, is there like any support group system for these children? So, like at PGI, or like, is there any work on creating a support group for the children of parents with mental illness?
sir, I encountered 2-3 support groups which one is there in Tri-City, which has recently come up. I think if my colleague is there, Dr. Nidhi, she is more aware of that. But there
Okay.
are others in Odisha. In
Okay,
Odisha,
sir.
there is one such group, and one such group is also there in Pune.
Okay, sir. Okay.
And
Thank you.
ji.
Yes. Yes, sir.
So Dr. Shinika and
Kanika?
Yes, sir. Yes, sir. Can
Yeah,
you
yeah,
please?
yeah, yeah. So if at all there are no questions, I will just like wind up the session.
Yes, sir.
Yeah,
We can,
please.
sir. Please,
Yeah,
sir.
please go ahead. Yeah.
Yeah.
So at the outset, I would like to thank our speaker for the day, Dr. AKHILESH Sharma sir, who took out his time to speak on this very, very interesting and as I just said, like generally we don't call the children, or we don't ask extra questions to discuss about their children's progress unless otherwise the parents themselves bring about the children for consultation. So whenever we see an adult with a mental illness, you have just really opened up this important aspect that we need to step up and just like interview the children, whether they are normally growing or how are they coping. Is there a parentification that is happening? So definitely, it is a very useful information, and the child talk manual that you have actually highlighted, sir. So it will definitely, we can actually look at like Indian version of it, so that like it can be helpful for children of Indian children with parents of mental illness. So I would like to take this opportunity to thank the Indian Psychiatric Society Tamil Nadu chapter, President sir, and all the EC members for giving us concern to actually proceed with this child psychiatry webinar series. And thank you all the participants for joining. And Dr. Shainika, who makes sure that like it starts on time and ensures that like the speakers are all chosen from areas who are actually they are working with. So it's a real pleasure to hear you, sir. And thank you so much for the opportunity. Thank you so much for joining in and just giving this delivery of lecture, sir. Thank you, sir.
Thank you, sir. I am thankful to IPS and Tamil Nadu Society. And I thank you all for giving me this opportunity. And I thank all the listeners who have joined and patiently listened to me.
Thank you very much, sir. Thank you for joining us again, sir. Thank you, sir.
Okay. May I leave, ma'am?
Yes, sir. Yes, sir. Yes, sir.